Hey, I'm Science with Chris, and today I'm going to be talking about GOG-279. This is going to be a little bit of a longer video compared to the YouTube short that I already created, but I'm hoping that you're going to be able to enjoy this slide deck and kind of follow along. Vulvar cancer is a rare GYN cancer, which predominantly affects postmenopausal patients, accounting for 0.3% of all new cancer cases within the United States. Beyond squamous cell, less common subtypes are melanoma, adenocarcinoma, basal cell, and sarcoma. HPV-associated vulvar cancer accounts for 70% of all cases and usually confers a more favorable response to treatment. The non-HPV-associated usually arise from vulvar dysplasia diseases and chronic inflammation like lichen sclerosis, and usually occurs in older patients. The most common diagnosed stage of vulvar cancer is stage 1, which is treated surgically and with lymph node assessment. Depending on risk factors, these patients can be candidates for radiation, and those risk factors would include close tumor margins, positive LVSI, tumor size, depth of invasion, as well as pattern of invasion, whether that be spray or diffuse. Stage 1A is managed with a simple partial vulvectomy, where 1B would include a radical vulvectomy, which include deeper tissue to the perineal fascia and would include a lymph node assessment. Locally advanced, for all intensive purposes, is defined as unresectable without removing proximal urethra, bladder, or anus, and so this would be surgeon dependent in that diagnosis. The primary treatment for locally advanced relies on chemoradiation, whereas historic treatments used to involve a pelvic exoneration, but more recent treatments have trended toward chemoradiation, and these treatments have been refined over the years. Initially, we ended up using cis and 5-FU and would split the course of radiation between APPA. The 3 trials that are going over locally advanced are listed right here, and the 2 that have already been previously published would be GOG-101 and 205. 101 is a phase 2, and most of these trials are all going to be phase 2 as well because vulvar cancer is a rare diagnosis. The chemo for 101 was given preoperative, and then it was followed by a radical surgical excision of the residual primary tumor. This was a study of 73 patients with T3 or T4 tumors, and the chemo was cis at 50 mg per meter squared, and 5-FU was 1 gram per meter squared per day for 4 days. The radiation for this, as listed on the slide, was 47.6 gray divided into 28 fractions, where 205, also a phase 2, used 57.6 gray over 32 fractions, plus concurrent cis at a little smaller dose of 40 mg per meter squared. This was a 20% increase in the radiation dose from 101, and the CPR was confirmed in 50% of patients in 205. And CPR stands for complete pathologic response, and that's going to be important for the rest of this lecture. The N for 205 was 58 patients for that as well. So moving on to GOG-279, this also is going to be a phase 2 study, and as we know, phase 2 studies mean that you don't have a control arm, so it's just like an experimental treatment and you just assess how it does. You can look at previous standard of care options and what their response rates or CPRs or ORRs were, and then you can kind of assess that with the phase 2s, but then really you have to confirm it with a phase 3 study. In this phase 2, we're using cisplatin and gemcitabine with IMRT. So there's 2 new variables that we're adding into 279. The number of patients are listed there, and those are the timings that they were allowed to accrue and enroll on the study. The objective is listed right there was, does gem and cis with IMRT increase the complete pathologic response in women with locally advanced vulvar cancer? Gemcitabine is new to the vulvar cancer space, but the regimen cis and gem actually has already been shown at efficacy within the cervical space, specifically with squamous cell carcinoma. And this is a Brewer et al. Study published in 2006, and this is GOG-9912. And in this study, gem was given at 50 mg per meter squared, and cis was at the standard 40 mg per meter squared. This study also was using APPA radiation. And then lastly, furthermore, given that IMRT is able to concentrate more of the radiation and spare the surrounding organs, an additional 12% more of radiation was used in this compared to the 205. And you know that 205 also had more radiation than 101. If you want to have more information, you can look at my gemcitabine video, but here's a brief understanding of what gemcitabine is. its cell cycle specificity, what its uses are, dose-limiting toxicity as well. Moving on to our methods for 279, we're looking at untreated vulvar squamous cell, and we're going to be using T2 or T3 with nodes of 0 to 3 and without any metastatic disease. Now, I want to take a moment to kind of explain that this is different than stage, where we jump back and we're looking at stage 2 and stage 3. That's a little bit different than T2 and T3, and the main difference really for this is that the T2 is looking at the primary lesion itself, and it doesn't account for the nodal status. So really T2 is any size of tumor that extends to the adjacent perineal structures, where T3 can evade the upper urethra, upper vagina, bladder mucosa, rectal mucosa, or is fixed to a pelvic bone. And therefore, T is different than stage, because stage 3 could have any type of T. It could have a T1, but if you had positive nodes, N1 or N2, you would still be a stage 3 disease, but not necessarily having a big bulky tumor, which is what is described as T2 or T3. Now that we understand that, our methods kind of go forward and say in patients that did have resectable lymph nodes, they underwent a surgery prior to receiving chemoradiation, and they undergo a unilateral or bilateral lymphadenectomy. Afterwards, they underwent chemo-RT, and this was gemcitabine and cisplatin, and then radiation was planned for a daily dose every 5 days per week in a 27 fraction cycle. After chemo-RT, in those patients with a complete pathologic response, confirmation with core biopsy was performed 6 to 8 weeks afterwards to determine the CPR, which is the primary endpoint for this study. Looking at our population, it was mostly postmenopausal and white. Only 4% were confirmed to be HPV negative, which is important to understand because HPV-related vulvar cancer responds more robustly to chemo-RT compared to non-HPV tumors. Now, if you look back and you understand when these patients were enrolled, you can kind of get a better understanding that really the HPV association and making sure that it was documented really only came about or was more prevalent when the WHO recommended it in 2020. So only a small sliver of patients within this population would have undergone standard pathologic assessment, which would include HPV status. Our primary endpoint was complete pathologic response, but first looking at the left side, since this is a phase 2 study, we're only looking at one arm, which is going to be our experimental arm, and we're looking at our PFS and OS. So out of the 57 patients that were in this study, the 12-month progression-free survival was 74%. The 24-month overall survival was 70%. The median PFS and OS actually has not been met yet for this trial, or at least the data hasn't been published yet. The median follow-up for all of our patients was 51 months. And then looking at the right side, out of the 52 patients that were able to be assessed, 6 did not have a status that was reported, and 9 had a clinically persistent disease after they got the chemo-RT. In those that had a complete clinical response, a CCR, 34 of those, which was a 92% of the ones that achieved CCR, ended up having a complete pathologic response. Interestingly, 9 of them that had a apparent clinical persistence of disease underwent a repeat biopsy or a repeat surgery, and what they ended up finding was actually 4 of those had a complete pathologic response, so those were reclassified into that CPR number, yielding us a 73% or 38 out of the 52 patients. The next part for this is going to be our toxicity assessment. Since we're adding on gemcitabine, and gemcitabine is very toxic for bone marrow, we wanted to look at and compare between 279 and 205. So on the left is going to be your 279 results, and 205 is going to be on the right side. And for a reminder's sake, there was 57 patients in 279 and 58 patients in 205. And what we show here is that there was more grade 3 plus anemia in 279 versus 205, and that was 35% versus 5%, as well as thrombocytopenia grade 3 plus, which was 35% versus 5% as well. Additionally, we were giving a higher dose of radiation, but this was more localized. But that being said, even though there was the increase of radiation and it was more localized, we did see more radiation dermatitis in 279. For the grade 3 plus for that, it was 32% versus 10%, which was found in the 205 study. So the conclusions for GOG-279 is that, yes, IMRT with GEM and CIS do improve CPR, complete pathologic response. We also find that when we're adding on gemcitabine, there was increased hematologic adverse events, specifically So for GOG-279, yes, we did meet our primary endpoint of complete pathologic response, and that was giving IMRT with gemcitabine and cisplatin. We also showed that adding on gemcitabine, though, did increase hematologic adverse events, and there have been other studies that have come out that have increased the dose of radiation administered without adding on additional chemotherapy beyond cisplatin, and they have also had improvements in their complete pathologic response, which the paper does talk about as well, and can make providers come to the conclusion that in patients with locally advanced vulvar cancer, the agent that might have the most benefit for our patients is really going to be the radiation dose. So while this wasn't a finding, it is important to kind of consider that maybe IMRT and radiation in and of itself can be beneficial. That being said, there is data to show that there is a synergistic effect with cisplatin and gemcitabine. Both of them are going to be radiosensitizing agents, so there can be probably some additional benefit when you're adding on those two versus just giving IMRT with cisplatin. But that's the simple breakdown of GOG-279, the more you know.